Good afternoon, everybody, and welcome to Dr. Bonura's eighth Lunch and Learn, eighth in a series of women's health lectures. Dr. Bonura, as many of you know, is a gynecologist in private practice. He is director of the Women's Health Program and director of the Osteoporosis Program here at St. Catherine of Siena Medical Center, and he has a private office here in Smithtown where he's seeing patients both in person and via telehealth. So without any further ado, I'd like to introduce Dr. Bonura, who is speaking today on female sexual dysfunction.
Ladies, this is the eighth of our series of Zoom programs on female issues. Our topic today is female sexual dysfunction. Recently, there was a study in our literature in which they interviewed in the United States 30,000 ladies of all ages. And what they found was that 45% of these ladies had some form of female sexual dysfunction, and 22% of these ladies were disturbed by it. They were concerned about it. Next slide. The types of sexual dysfunction that I see mostly in my practice are one, female sexual desire disorder and arousal disorder. And I also see, since I'm director of the menopausal program at a hospital at St. Catherine's, I see the genital pelvic pain and penetration disorder. Occasionally, we see patients with substance or medication-induced sexual disorder, and rarely we see patients who have female orgasmic disorder. Now, a healthy sexual function includes sexual desire, genital arousal, central arousal in your brain, orgasmic ability, and pain-free sexual activity. Next slide. Dr. Bassan made a slide in normal sexual response. She said that women require emotional intimacy. They have to be in a safe environment. They have to have good self-esteem, and they have to have an attractive partner. And then with sexual stimuli, they develop arousal. They develop then desire and arousal. They have an orgasm and then resolution. Next slide. It's more complex than that. Sexual arousal begins in the brain after sexual stimuli. The top picture is a picture of your brain. And in that area, the area of sexual arousal and desire occurs in a small area of the brain that we call the hypothalamus. And what happens with sexual stimuli, the nerve cells release neurotransmitters. These are substances that affects this area and increases excitement and arousal in your brain, these neurotransmitters. And they also send a signal to your blood supply of your labia, your clitoris, and your vagina to increase blood flow. So you have an increase in lubrication. There's also relaxation of the smooth muscle that surrounds your vagina so that the vagina dilates. In the left lower quadrant, in the reproductive years, your ovaries produce hormones that increase desire and arousal in your brain. And in the reproductive year, the ovaries produce hormones that increase blood flow to your labia and into your vagina. And in the vagina, what estrogen does, it increases the thickness of the walls of the vagina. It increases the elastic fibers and collagen fibers so the vagina can dilate. It also increases lubrication in the vagina. Next slide. In the brain, the neurotransmitters, and we're going to talk about them later when we talk about the therapy, that increase desire and arousal and excite a person would be the main ones are dopamine and melanocortin. The ones that inhibit are serotonin. And there's a balance between the ones that excite and the ones that inhibit in women who have normal sexual activity. Next slide. So here's that slide that shows them again. Increase in desire and arousal would be the female hormones, estrogen, progesterone, testosterone, and the neurotransmitter would be melanocortin and dopamine, and the ones that inhibit the sexual desire and arousal would be, main one would be serotonin. Next slide. The hormones produced in your ovaries in the reproductive stage of your life work on your brain in that center to excite you and arouse you. And they also work on the blood flow to the vagina. And by increasing blood flow to your genitalia, there is an increase in collagen, an increase in elastin fibers. Your vagina becomes thicker and it becomes lubricated. But when you're menopausal, you're not producing estrogen, so you miss this part. Next slide. Let's talk about low sexual drive, low sexual arousal in women, because that's the major problem that I see in my practice in women who have sexual dysfunction. Now, there are two types. One is due to something other than your brain. That's called secondary causes of low sexual desire or arousal. The other type is primary type due to the imbalance of neurotransmitters in your brain. Next slide. This is a case study that I usually see in my office. It's a lady in her late 40s, 50s, or 60s who's been married for 15 or 20 years. And she says, Dr. Bonura, for the last 5 or 10 years, I no longer have any sexual desire. It's been occurring and it's causing a problem with me. I'm distressed about it because I love my husband and I have duty sex once or twice a month because out of sympathy for my husband, and it's creating a problem for me, for my marriage, and I want something done about it. Next slide. Lack of sexual desire is the most common condition that we see and can be in women of all ages. They have no interest in sexual activity. They have no sexual fantasies. They don't respond to sexual stimuli despite having a good relationship with their partner. It has to last for 6 months and it be a disorder. It must cause personal distress. But more than 50% of women that I see have lack of sexual desire and arousal, and it doesn't affect me. They live with it. The ones that we treat are those women in which it causes a personal distress. Next slide. Some of the secondary causes of decreased sexual desire can be due to physical causes such as illnesses, physical changes of your body, medication or drugs that you're taking. Some of the medical diseases that we see are arthritis. If you're in constant pain, you have a decreased desire for sex and you have a decrease in your sexual arousal. We see it in women who have diabetes, high blood pressure, heart disease, cancers of any sort. We see it with medications. The major medication that we see, the antidepressants, when you take an antidepressant, it increases serotonin in your brain, and that inhibits sexual desire and arousal. We see it on people who take cardiac drugs. We see it on women who take drugs for hypertension. We see women who have diabetes, diabetic drugs, and we see women who have breast cancer who are on the aromatase inhibitors. Next slide. Some other causes, secondary causes of decreased sexual desire and arousal can be fatigue, taking care of your children, taking care of your husband, taking care of your aging parents. But it can also be due to lifestyle habits. Alcohol decreases desire and arousal in you and in your mate. Smoking, cocaine, marijuana, surgery that affects your body image. If you've had breast cancer surgery, have a breast removed, or your breast is distorted with scars from the surgery, or any kind of genital surgery. Next slide. Other causes of decreased sexual desire and arousal can be hormonal changes. In menopause, there's no female hormone, no estrogen. The vagina becomes thin, it becomes constricted, and you have painful sex. You don't want to be bothered with sexual activity. We see it in psychological causes. People who have anxiety, depression, a poor body image because you've gained a lot of weight, low self esteem, a history of physical or sexual abuse, financial stress. Another major cause that we see that after you're married 20 or 25 years, you've lost interest in your partner. You lack a connection with your partner. Next slide. The treatment for the secondary causes after we are able to determine what your secondary causes are, we tell you to do lifestyle changes. We tell you to lose weight. We put you on a healthy diet, and the diet that we recommend always, if you look at any of my videos on my webpage, is the Mediterranean diet. We recommend that you exercise every day for at least an hour. We recommend you stop smoking and get enough sleep. This all these lifestyle changes increase your sense of well-being. We manage your medications. We may lower the doses of some of your medications. We may switch your antidepressant to a type that doesn't affect your sexual desire or arousal. And if you have painful sex, we may order moisturizers or lubricants, and in some cases, vaginal estrogen. Next slide. The second type of decrease in sexual desire and arousal is a condition that affects that center in your brain that produces the neurotransmitters. Next slide. Before we treat that condition that affects your brain, we rule out you have no organic causes, no medical causes, no psychiatric conditions, no medications that you're taking that affects the center in your brain, and you're not abusing any substances such as pain medications, morphine, cocaine, alcohol, and you have no relationship stresses. They can't contribute to your condition. We have to rule these out to determine your condition is due to an imbalance of your neurotransmitters. Next slide. After we rule these all out, we ask you questions. We use a decreased sexual desire arousal screener. We ask first question. And listen to this, ladies. In the past, was your level of sexual interest or desire good? And you answer yes. Has there been a decrease in your level of sexual desire or interest? You answer yes. Are you bothered? This is the most important question. Are you bothered by your decreased level of sexual desire or interest? If you say yes, that's very important. The last question, would you like your level of sexual desire or interest to increase? You must say yes to all of them. Next slide. We then ask these 6 questions. Have you had any operations? Are you depressed? Or do you have any medical conditions? Are you on any medications, drugs, alcohol, cocaine, or marijuana? Three, are you have any menopausal symptoms? Hot flashes, vaginal dryness, pain with intercourse. Does your partner have sexual problems such as erectile dysfunction? Are you dissatisfied with the relationship with your partner or with your partner in general? Do you have stress, fatigue, or body pain? You must answer no for me to make the diagnosis that you have a problem with your neurotransmitters in your brain. Next slide. After asking these questions, we do a pelvic exam to make sure you have no gynecological problems after we take your history, of course. And then we may order labs on you, such as we may order hormone levels, we may order a thyroid test, we check you for diabetes or hypertension. And in some occasions, we may even refer you to a sex therapist. Next slide. If we've made the diagnosis that it's an imbalance of the neurotransmitters in your brain, the therapies, the pharmacological therapies that are approved by the FDA are one, flibanserin has been approved in me premenopausal patients. I don't use that in my practice because the side effects are dizziness, drop in your blood pressure, and fainting. And there's a black box warning about taking alcohol with this drug. You cannot take it with alcohol. It can cause serious side effects. So for that reason, we don't use it in my practice. Next slide. What we do use, and it's approved by the FDA, is Vyleesi. Vyleesi stimulates your brain to increase melanocortin and dopamine, which increases desire and arousal. The original studies were in premenopausal patients, and it increased sexual interest, arousal, desire, arousal, and orgasm. And it's a self-administered, it's a tiny needle. You give it underneath your skin 45 minutes before you are going to have intercourse. And you can't use it more than 8 times a month. The side effects are nausea and headache, but many of gynecologists or in our practice, we can use it off label in menopausal ladies. Next slide. What is not approved off label by the FDA in menopausal women, we know that testosterone can increase desire and arousal in your brain. And we know that transdermal testosterone, it's a cream. It's usually used for men, but off label, it's 1% cream. You use 5 milligrams and you rub it in your skin, and it increases desire, orgasm. The side effects can be acne, increase in hair growth on your body. You can develop deepening of your voice, and we recommend that we check your cholesterol level and your liver functions. Another one that can be used off-label is a antidepressant called Wellbutrin or Buspar, which we also use to stop smoking. What Buspar is, you would take this pill every day. It's an antidepressant, and it stimulates in your brain dopamine and increases your desire and arousal. Another one off label in women who are premenopausal, who don't have any secondary causes of decreased desire or arousal, who are on antidepressants, studies show that Viagra can work in these ladies. Next slide. The next type of sexual dysfunction that we see in my practice, because I'm a menopausal specialist, is the genitopelvic pain and penetration disorder. In these women, they have difficulty with vaginal intercourse, and the reason for it is it causes pain. So they have fear of pain, they have tensing and a tightening of the pelvic floor muscle, And who would have intercourse, whether you're a man or a woman, if it's going to cause pain? So there's a decrease in sexual interest and a decrease in sexual desire. Next slide. The next slide shows a picture of the lateral walls. That metal object in the center is the speculum that we use when we do your pap test. And normally in the reproductive stage of your life, that is in your premenopausal stage of your life, your vagina is elastic, it dilates very easily, and the walls are pink. This lady is menopausal, her walls are white, and there's little areas, punched out areas of hemorrhage, and there's no elastic fibers in the vagina, and there's no collagen, so the vagina shrinks and it gets shorter. And when her mate tries to penetrate, it elicits pain. Next slide. Now, how do we treat women who have the genital pelvic penetration or pain with intercourse condition? Well, we use moisturizers, we use lubricants, we use vaginal dilators, we use pelvic floor muscle training with biofeedback, we use vaginal estrogen, we use intrarosa, which is DHEA, and we use lidocaine ointment in the opening of the vagina, and that would be something that decreases pain. It's a type of a local anesthetic cream. Next slide. Let's go into these in a little depth. What vaginal moisturizers do? I use a moisturizer on my face every day. What vaginal moisturizers do is they increase fluid in your vagina. They don't change the anatomy, but they take away vaginal dryness. And the ones that we use are, in our practice, are Luvina, and we also use KY, and they moisturize the vagina. And we recommend that when women have intercourse, they use a lubricant to take away friction with intercourse. And the lubricants that we recommend are Astrogride or a platinum. You can get them over the counter, and you would use it, and your sexual partner would use the lubricant. We also recommend regular sexual stimulation, and that can be with a partner. It can be you using your finger or manually, or the use of a vibrator 10 minutes every day or every other day. And in our practice, if you really have constriction of your vagina, in our office, we stretch your vagina using vaginal dilators, and we may even order them for you for your use at home daily. And we have a program in our practice called the FemiScan program. It's a pelvic floor muscle exercise program with biofeedback, so you can see whether you're improving or not. These are the non-hormonal remedies. Next slide. The gold standard for women who have this problem is vaginal estrogen. Vaginal estrogen increases blood supply to the vagina. It makes the lining of vagina thicken. It increases the elastic fibers. It increases the collagen in the vagina, and increases the lubrication in the vagina. And we use low dose local vaginal estrogen. We even use it in women who have had breast cancer. We even use it in women who have had cancer of the ovaries and cancer of the endometrium, providing that we check before we order these medications with their oncologist. If the oncologist approves it, then we use these medications. Next slide. And we use bioidentical products. We use vaginal estrogen on the top, comes with an applicator. In the middle, that blue tube is called Vagifem. It's a little tablet, bioidentical. And the third thing, the ring on the bottom, is used once every 3 months, and it gives a very low daily dose of bioidentical estrogen. Next slide. Some of the non-estrogen therapies that we use in our practice, we use DHEA, which is intrarosa, vaginal suppositories. We haven't used the other two. Uh, Something new now is microablative fractional carbon dioxide laser. It's a probe that's put in the vagina. The laser is turned on. They make these micro holes that increase vaginal thickness, collagen, and elastic fibers. But the procedure is not covered by insurance, and the procedures can range anywhere from 1,500 for 3 visits or even higher. So we don't use that in our practice. Next slide. The third type of sexual dysfunction that we can see is substance or medication-induced sexual dysfunction, in which alcohol, marijuana, cocaine, sedatives, pain medications, and antidepressants decrease desire. So what we try to do is limit them or change the medication with your physician, your family doctor or internist. Next slide. Rarely what I see in my practice are female orgasmic disorders. They can be primary. Primary means you've never had an orgasm. Most of these ladies that never have had an orgasm have had a childhood trauma. Usually it is sexual abuse as a child. Secondary can be from medical conditions, medications, or body changes. And many times we refer these patients who have primary or secondary to a psychiatrist or psychologist with expertise in sexual problems. That's the last slide. What I say to you ladies, if you have any female sexual problems or dysfunction that you're concerned about, you should mention them to your physician. And many of you ladies can be helped. One last thing, talking about the coronavirus. Everyone should wear a mask. Secondly, social distancing. Thirdly, you should exercise every day. You should eat a balanced diet. And some studies show that vitamin D can increase your immune system. And lastly, if you're eligible or someone offers you the vaccine, take it. I got it. There are really no serious side effects to it, and it can save your life. Now, if anyone has any questions, you can ask them now, or you can call my office, or make an appointment and come in, and we can go over your problem.
Thank you, Dr. Bonura. That was
It was
excellent.
very informative.
Do we have any questions? Just unmute yourself, or you can put something in the chat and I'm happy to read it out for you.
I'm good. This is great.
Dr. B checked off all the boxes, gave us all the information we need just in time for Valentine's Day. So we're all ready.
All righty.
Oh, here's a question.
there's a
What does the term off-label mean, Dr. Bonura?
Sorry,
What does the term off-label mean?
I can't hear you.
What does the term off-label mean?
Oh, off-label mean not approved by the Federal Drug Administration, but we use a lot of medications off-label in obstetrics and in gynecology. It's just not approved by the government.
Okay. Excellent.
Lastly, ladies, if you're interested in any of the other videos, go to my webpage, frankbonuramd.com, and click blogs, and you can see all the other 7 ones that we did on various women's issues. We did them on menopause. We did them on drugs on menopause. We did it for men and women on osteoporosis and the drugs. We did it on abnormal uterine bleeding. We did it on vaginitis. So if you're interested, just go to that webpage.
Dr. Bonura, I have a question.
Our phone number is 631-724-6262. And we'll be only too happy to answer your questions. You can call me up or make an appointment and we'll go over your problem. So enjoy your lunch. I'm going to have my lunch next. And we'll see you next time.
Okay, thank you.
In Italian, we say, buongiorno, ci vediamo, ciao.
In Spanish, we say adios. Bye-bye. Thank you.
Bye, girls.